Celeste Orr is a visiting assistant professor at St. Lawrence University in the Gender and Sexuality Studies Department. Their research explores the complex, discursive, embodied, and political connections between intersex and disability. Dr. Orr's book, Perspectives, Cripping Intersex, Compulsory Didactism, and Biological Exorcism, has been accepted by UBC Press for the Disability Culture and Politics series. Dr. Orr is currently finalizing their manuscript for submission. Dr. Orr's research is also featured in a number of journals, including Mothering, Mothers, and Sport, Experiences, Representations, Resistances, Connecting, Rethinking, and Embracing Difference. Their research will also soon be found in From Band-Aids to Scalpels, Motherhood Experiences in/of Medicine, Boyhood Studies, and Interdisciplinary Journal, Non-Sovereign Bodies, Law, Land, and Gender Justice, and Intersex and Health and Medical Humanities. Dr. Orr is also in the process of co-editing a special issue of Feminist Theory, marking the advent of feminist loneliness studies. Dr. Orr's interdisciplinary training includes a BA, double majoring in philosophy and English literature, an MA in philosophy, a MA in cultural studies and critical theory, as well as a PhD in feminist and gender studies. Their doctoral research was supported by 5 scholarships, most notably the Social Sciences and Humanities Research Council, Joseph Armand Bombardier Canadian Graduate Scholarship, Doctoral Scholarship. Wow, that's an exciting, impressive bio. So please welcome Dr. Orr.
Hello, everybody. Thank you all for joining. I'm really enjoying reading everybody's little introduction, so I really appreciate it. As Shannon noted earlier, there are the links above for the, the document of my talk. And also I have some slides today. So I'd first like to start by thanking everybody who helped organize the event. Shannon, thank you so much. You've been really lovely and helpful during this process. And I also want to thank all of you for tuning in. I'm really excited by the cross-discipline or interdisciplinary or perhaps undisciplined potential of this exchange today. So I'm going to spend about 25 minutes addressing a few of the arguments developed in my forthcoming book, Cripping Intersex. And then I'll take a few minutes addressing my future research that concerns the medical field. So I really look forward to hearing any of your thoughts or ideas during the question period. Oh, wait, I guess I can do, oops, just a minute. Slideshow. Away from current slide. Yeah, oh, wow, look at that. Okay. Oh, wait, no, then I'm gonna have to leave it like that or else I can't see my notes. So I'm gonna start by offering up a definition of intersex. So we're all on a similar or same page. Intersex is an umbrella term used to describe biological characteristics that lie between the traditional Western male-female sex binary. As you know, the medical or medicalizing phrase is disorders of sex development or DSDs. And I say the male-female sex binary is Western because the sex binary has been and is still used as a Western colonial imperial tool to erase, rename, and repathologize various indigenous identities that don't conform to the Western sex gender binary, such as two-spirit or he/her identities. So we can't conflate intersex as an identity or social category or diagnosis with any indigenous identities. Intersex is a Western concept, so imposing it or conflating it with indigenous identities is a colonial imperial act. So, some of the big questions that animate my book include, given that intersex is largely understood as an innate pathology, disorder, disability, or disease, what are the political, discursive, and embodied connections between intersex and disability? What might be gained by understanding compulsory able-bodiedness as a key concept in intersex studies. So compulsory able-bodiedness is a term mobilized by disability studies scholars to describe the ableist cultural mandate that people have to be able-bodied, that we should never have disabilities. So what benefits would accrue from integrating feminist disability and Crip theory into intersex studies? So Crip as a term and identity emerged in disability movements as a reworking and reclaiming of the pejorative word cripple. And Crip theory, in short, is the merger of disability and sexuality studies and aims to undermine compulsory able-bodiedness and heterosexuality, and it aims to understand how disability and queerness intersect. So, to answer these questions, I place intersex studies in conversation with feminist disability studies and Crip theory to see if, how, when, and why disability and compulsory able-bodiedness intersect with intersex and compulsory dietism. So, sorry, I know I'm throwing out a lot of terms at the beginning. So compulsory dietism is a term that I developed and I use to describe the instituted cultural mandate that people cannot have intersex traits, defy the sacrosanct Western belief in the male-female sex dyad or binary, or house the specter of intersex. Such a specter is often assumed has to be exorcised. So Cripping Intersex examines several sites of compulsory dietism, such as medical terminology, medical treatment, sports sex testing, sports sex and disability segregation, and reproductive technologies. But today, I'm just going to focus on medical terminology and management, as well as past and present medical conceptions of sexual ambiguity. In doing so, I emphasize that we can't deconstruct the sex dyad without attending to the ways compulsory dietism is rooted in interconnected queerphobic, ableist, and racist ideologies. So, roadmap, these are sort of the sections I'm going to go through. Introduction, what's intersex, monstrous queers, introducing compulsory able-bodiedness, cripping intersex studies, the racialized intersex specter, and then a few minutes on my future work. So, what's intersex? According to many medical professionals, intersex is an innate disability, disease, or disorder, a disorder of sex development that requires immediate curative intervention. In a horribly ironic twist, in the attempt to reorder the supposedly disordered intersex body, medical procedures often cause disabilities. So these procedures are debilitating. So PTSD, depression, anxiety, genital pain, inability to experience orgasm, chronic infections, suicidal ideation, etc. And many people require more operations because surgeries fail, and some don't identify with the gender that was socio-medically assigned, resulting in dysphoria or dissociation. So borrowing Kim's expression, intersex medical management constitutes curative violence. So Kim employs the expression curative violence to describe the exercise of force to erase differences for the putative betterment of the other. Curative violence occurs when cure is what actually frames the presence of disability as a problem and ends up destroying the subject in the curative process. So to resist pathologization and disabling curative violence, most intersex studies researchers, scholars, and activists insist intersex isn't a disorder, disability, or disease. Drawing from feminist sexuality and queer theories, many contend, and rightly so, that compulsory heterosexuality fuels the medical or medicalizing response to intersex. However, I argue that these analyses fall short because intersex is actively being integrated into conventional ableist notions of disability by the medical industrial complex. When it comes to treating intersex, compulsory able-bodiedness and dietism are quite indistinguishable. The debate over what intersex is and how it should be treated hinge on what disability, disorder, and disease mean. And we know many disability labels or diagnoses have ableist, colonial, racist, and queerphobic roots. So if what intersex means hinges on what disability means, we have to attend to this full discriminatory complexity. We can't just focus on compulsory heterosexuality. So as a result, I propose a Crip Intersex studies. So this field examines the political, discursive, and embodied connections between intersex and disability, compulsory dietism, and able-bodiedness. So I think this field is really needed right now because due to the intersex rights movement, intersex is entering mainstream conversations like never before. However, some activists and scholars reproduce ableist logics and reject disability entirely. A Crip Intersex studies ensures anti-interphobic projects don't reproduce ableist discourses, and it identifies and develops the necessary tools to combat the ableism that underpins compulsory dietism and current medical management. So intersex and disability scholarship and activism must be politically linked. And intersex and disability are already discursively connected, experienced, and embodied. So monstrous queers, compulsory dietism, and heterosexuality. So after Vincent Guillot's mother gave birth, she was told she had given birth to a monster. Of course, Guillot and other intersex people aren't monsters or monstrous. Rather, they threaten compulsory dietism and therefore heterosexuality. Many medical professionals understood and still understand this threat and mobilized queerphobic rhetoric to justify medical intervention. Many doctors claimed that medical intervention was necessary so intersex children develop exclusively male or female heterosexual identities. Writing about assigned girl intersex children in the 1960s, John Money claimed these children are psychologically and physically virilized or masculinized and must be fixed, so they don't develop lesbianism or bisexuality, apparently the horror, or possess male intelligence, whatever that is. So queerphobia and compulsory heterosexuality still motivate intersex treatment. So for example, the drug dexamethasone or Dex was advanced to prevent an assigned female fetus from masculinizing, developing intersex traits. So this intervention has been aimed at preventing development of ambiguous genitalia, tomboyism, and lesbianism. So likewise, the queerphobic rhetoric some doctors employ is evident in many intersex people's testimonies. So for instance, Laura Inter, which is a pseudonym, recalls doctors explained that she needed medical intervention so she could, quote, have sex normally with your husband when you get married, so she could have normal heterosexual sex. The fact that intersex medical management is a tool to maintain compulsory heterosexuality and dietism is quite clear. So introducing compulsory able-bodiedness, cripping medicalizing conceptions of intersex. So in my book, I examine a lot of ableist medical rhetoric, but I'm just going to address 3 today. So DSD, the threat of cancer, and the expression blind pouch vagina. So disorders of sex development. There was a move away from explicitly queerphobic discourse. Disorder, disability, and disease now dominate contemporary narratives about intersex. And this move was very clear when DSD was institutionalized in 2006. So in re-medicalizing fashion, DSD replaced intersex. The idea that intersex is a disorder was discursively solidified. So the institutionalization of this expression at this particular time is noteworthy. DSD was introduced just as the intersex rights movement was gaining considerable mainstream recognition, and when many intersex people were reclaiming intersex as a political identity, not a diagnosis. So DSD illustrates that intersex people are understood as violating compulsory dietism, heterosexuality, and able-bodiedness. But the violation of compulsory able-bodiedness is centralized, disorders of sex development. Centralizing the supposed disordered nature of intersex is really useful to doctors who believe that intersex requires cure. Given ableist logics, people with disabilities, disorders must be fixed. Also, DSD undercuts intersex activist work and depoliticizes intersex variations and identities. So I want to emphasize that DSD works to depoliticize intersex. It can do this work because disorders, disabilities, or diseases are often not recognized as political, but rather innately wrong and in need of fixing. So unlike explicit queerphobia, explicit ableist rhetoric is pretty much culturally admissible because ableism is often not recognized as a form of oppression or discrimination at all. So the threat of cancer. The ableism that underpins intersex medical management is clear when doctors like Dr. C claim that talking about DSD is like talking about skin cancer and brain cancer. The analogy is distinctly misrepresentative. One can't potentially die from intersex traits themselves. However, comparing intersex to fatal diseases enables one to justify eradicating intersex. But cancer isn't just used as an analogy. Some medical professionals claim intersex people are at a greater risk of developing cancer in their gonads, so they must be preemptively removed by a gonadectomy. Parents' fears of illness, disability, and death are exploited to uphold culturally mandated ways of being. But the risk of developing cancer is often hard to predict, and claims of cancer development are contested and regularly inflated. And also, gonadectomies result in sterilization and lifelong hormone replacement therapy dependencies, or HRT dependencies. And one's risk of developing cancer actually increases because of long-term HRT use. Risk of cancer can dissipate once HRT is stopped, but surgery literally removed that choice from these intersex individuals. Ironically, to ostensibly prevent cancer, one's risk of cancer actually increases. So remarking on the inflated claims of cancer, intersex studies scholar and activist Morgan Carpenter, depicted there, states, the lifetime risk of breast cancer in women is 12.2%, but we don't routinely remove women's breasts on the basis of that cancer risk. Sterilization, gonadectomies turn us, intersex people, into lifelong patients, even if it's the only intervention carried out. We need HRT. If cancer is truly a risk, routine cancer screenings can take place like pap tests or mammograms. So blind pouch vagina. Ableist metaphors are often used as a crutch to justify curative violence and compulsory dietism. So blindness here is a metaphor, blind pouch vagina. Blind pouch vaginas are apparently blind because they're too short, may not have a properly formed uterus or cervix, or have a uterus or cervix at all, and they may be infertile. To make the vagina see, vaginoplasties are often performed. Vaginoplasties can cause infertility. The constructed vagina can smell like a bowel. It can necessitate constant use of sanitary napkins, and it frequently requires repeated surgical revisions. In addition to vaginoplasties, dilators, which are hard dildo-like instruments, are often used to make sure the vagina doesn't go blind again. Or if surgery wasn't performed, dilators non-surgically deepen the vagina so it can see better. Unsurprisingly, dilation is often very painful and humiliating. According to ableist logics, blindness is a disabling lack or loss that must be avoided or cured. So labeling these people's vaginas blind is an ableist tactic to reaffirm the supposed necessity of vaginoplasties and dilation. So what do these vaginas apparently need to see? I suspect what you're thinking, or perhaps typing, I can't see right now, is correct. Apparently they need to see penis. These vaginas are apparently blind to their supposed heterosexual feminine destiny, blind to the apparent wonders of heterosexual penetrative sex, blind to the phallic spectacle. So the end goal is, in Curative's terms, make the hermaphrodite fuckable for prospective heterosexual men with penises. They're rendered disabled because they can't fulfill heterosexual expectations. So the underlying queerphobia here is masked by ableist rhetoric. The term pouch, I find, is also really disconcerting. Pouch implies vaginas are merely lithe depositories for a prospective penis, depositories that can be reformed for the user's purpose, but the presumed user in this scenario is a prospective man with a penis. Access to this pouch or the future contents of this pouch are not attributed to the rightful owner, and the architect in this context is the doctor. So intersex activist Emily Quinn demands, please stop talking about my vagina like it's some weird purse, a disabled pocket failing to hold the proper contents. So some medical scholars insist dilation is, quote, an effective treatment choice resulting in good outcomes and good cosmetic and functional results, end quote. Yet many intersex people and studies testify to the disabling effects of dilation. In fact, even studies that claim dilation had good results report patients experiencing anxiety and anguish in relation to dilator use, avoid engaging in sexual activity because doing so is painful, and experience vaginal stenosis, friable tissue, chronic UTIs, and urinary incontinence. So intersex activist Claudia Astorino writes of her dilation experiences. Imagine a man as old as your father or your grandfather who you don't know inserting a medical dildo into you each time you saw him, knowing that you can't question the doctor's orders and just accept that you have to undergo these uncomfortable procedures for your health. Imagine a decade or so later realizing that these procedures did nothing to track your health and have everything to do with grown men feeling good about the fact that you could fuck some dude someday like a normal girl. So these procedures are medically unnecessary, but they're justified via ableist metaphors. No one needs a vagina or one that can see unless they express such a need and can consent to the required procedures. We really need to pay more attention to how ableism is discursively mobilized to justify irreversible curative violence so we can identify it and combat it. So cripping intersex studies. So in the attempt to undermine doctors' assessments of intersex, some intersex activists insist intersex is not a disability, disease, or disorder. So consider, for example, these quotes. Intersex is not a medical condition or a disorder or a disability or a pathology or a condition of any sort. Likewise, summarizing an interview with Marissa Adams, an intersex person, Kaplan Bricker writes, we, intersex people, aren't disordered. A participant in Georgianne Davis's studies explains, nobody wants to be a disorder. Who wants to be a fucking disorder? I don't. Carrie Gabriel Costello states, I'm not defective, I'm not disordered. I recognize the utility in theorizing about the nature of disability and analyzing the complexities involved in claiming disability or Crip as an identity. However, this type of examination isn't really happening. So I interpret these sorts of statements as stigmaphobic distancing from disability. So given cultural perceptions of disability as lack, loss, or pathology, some intersex folks vehemently refuse any association with it. Due to ableist perceptions of disability, some intersex folks don't align with disability because of the belief that doing so will worsen their position. However, disorder or disability ought not be conflated with curative violence. There doesn't need to be a wholesale rejection or re-stigmatization of disability. Doing so reproduces ableism and doesn't undermine ableist understandings of intersex. If one implies that disorders, disabilities are innately undesirable, they implicitly support doctors' evaluations of disabilities. So a Crip intersex approach ensures this doesn't happen. So, while a handful of intersex studies scholars and activists draw from disability studies, to their detriment, most don't. Most draw from feminist, gender, queer, and sexuality theories, and as a result, fall short. However, drawing from feminist and queer theories, many intersex studies scholars underscore the fact that the sex and gender binaries are a farce. And these sorts of theories are crucial to intersex studies researchers because they illustrate how and why doctors administer, give, or design sex to uphold compulsory dietism. They're also crucial because they help intersex studies scholars and activists argue that medical intervention constitutes intersex genital mutilation, or IGM, torture, sexual assault, and human rights violations. So cripping these analyses reveals a more complex story. The sex dyad is rooted in both queerphobic and ableist conceptions of healthy normal genitals. A Crip intersex approach therefore brings into focus precisely how compulsory dietism and able-bodiedness are intertwined, why medical practitioners mobilize ableist discourses, how we can resist pathologization without reproducing ableism, and how we can crip or destabilize categories of meaning and reimagine the relationship between intersex and disability. And centralizing disability also offers up a new narrative concerning the embodied effects of medical intervention. So the narratives noted earlier, mutilation, sexual assault, torture, these are vital in the battle against curative violence, but the consequences should also be understood as disabilities. These are debilitating. So this narrative, framing them as disabilities, better highlights the tragic irony. Curative medical interventions often cause disabilities. Considering the outcomes of curative violence as disabling underlines that an intersex with disability politic and a Crip intersex studies is crucial. We can't simply undermine the sex dyad without attending to the disabling embodied consequences of medical management. So intersex activist Emi Kwayama reveals some of the benefits of cripping intersex. So she writes, quote, "Critical disability theories point out that our flesh and bones are consistently given meanings and interpretations through social structures. To a disability theorist, disability is not simply a characteristic of one's body, but the product of social institutions that divide human bodies into normal and abnormal, privileging certain bodies over others. In this view, the physical condition that necessitates the use of a wheelchair in order to move about is not itself a disability. Social and architectural structures that deprives a wheelchair user of full participation in society is what disables her." Similarly, intersex activist Esther Morris's observation that not having a vagina was not my problem, having to get one was, can be rephrased to say, not having a vagina was not a disability. The social expectation that she needed to get one in order to live a happy and productive life marked her as disabled. So by appealing to disability studies, Kwayama underscores the fact that assessments of sex disorder are ideological, not objective allegations. So situating intersex alongside disability reveals intersex studies and an intersex politic requires an intimate relationship with disability studies and politics. So cripping intersex offers up more nuanced theorizations about exactly how intersex people are discursively and literally rendered disabled. So the racialized intersex specter. Approaching intersex issues through a Crip intersex lens prompted me to dig deeper into the idea that the sex binary and compulsory dietism are Western ideologies. So what does it mean to claim that the sex dyad is Western? This question has rarely been addressed in intersex studies literature. The ways racism, colonialism, and imperialism has shaped and continues to shape compulsory dietism is largely ignored. So for instance, there is a long Western colonial, imperial, and racist scientific history of labeling African women's genitals ambiguous, primitive, malformed, or malconformed. So in 1863, for example, Theodore Waits claimed this phenomenon is, quote, "a fixed peculiarity of race." So, yeah, that's right. So many colonizers claimed that these ambiguities were literal markers of innate deviance, degeneration, and primitivism. So before doctors mobilized explicit queerphobia in the 20th century, racist rhetoric dominated conversations around sexual ambiguity. So text published well into the 20th century perpetuated the false idea that African people and Black people are more likely to be sexually ambiguous. Echoing Waits, Godfrey Charlwood wrote in 1956, intersex abnormalities are more frequent in, quote, Negroes and related races, end quote. In 1988, Michelle Ramsey and colleagues similarly claimed, quote, ambiguous genitalia seem to be much more common in Blacks than whites, end quote. So while queerphobic rhetoric was being mobilized at this time, racist conceptions of sexual ambiguity were still present, albeit fading from dominant narratives. And we know Western sex categories have colonial, racist, queerphobic, and ableist roots. As a result, we really need to take race, citizenship, and nationality into account. We must fully acknowledge the fact that racism, ableism, queerphobia, and interphobia are not distinct forms of discrimination. So intersex activist Sean Saifa M. Wall states, "I'm not just intersex, I'm Black and I'm queer." He's not simply listing off his identities. He draws our attention to the fact that we can't understand his identities or discriminatory forms of violence in isolation. So Wall states elsewhere, "I stand at the intersection bearing witness to how racist violence has incarcerated my friends and loved ones, as well as being subjected to interphobic, medically unnecessary surgical intervention." So the logics of interphobia, racism, queerphobia, and ableism interconnect and fuel all sorts of violence: racist science, slavery, colonialism, medical management, incarceration, pathologization. So it's vital to underscore the racist historical construction of sexual ambiguity and how that construction maintains compulsory dietism and actually spans over centuries. So my Crip intersex approach helped me track these overlapping shifting discourses from racist, queerphobic to ableist. Whatever form of oppression is explicitly admissible by dominant Western colonial white forces, that form of discrimination has been overtly mobilized to justify the Western sex dyad. While one narrative may dominate during a specific time, they remain braided together and must be understood as still working together. So a very brief conclusion before I then briefly touch on my future research. So male, female, or disordered sex are not essential characteristics. As Suzanne Kessler explains, how hard one looks at genitals and what one sees or does not see is not constrained by the optic nerve, but by ideology. We have to pay more attention to the interconnecting ideologies that inform what we see. Doing so requires a Crip intersex studies. So a couple more minutes. So future research. My future research, I really want to take up questions concerning medical education. I want to explore what prospective medical professionals in Canada are taught about intersex in classrooms and in medical textbooks. Figuring out what they're taught and what needs to change can really lead to some radical systemic changes in education. So I want to ask and answer the following questions. What discourses are used to describe intersex? How are future medical professionals instructed to understand and care for intersex patients? Is this instruction underpinned by intertwined discriminatory ideologies? Is this education representative of intersex people's needs and wants? And does this education prepare them to successfully care for, advocate for, and treat intersex patients? My preliminary research suggests that there's much room for improvements. It seems like a lot of medical professionals are taught very little about intersex. Also, intersex or DSD is not mentioned at all in many medical textbooks used to teach prospective medical practitioners. And when intersex is mentioned, the text might include decades-old photographs of naked intersex people, emphasizing their genitals, and they're typically children, always white children. So echoing arguments made by disability studies scholars, intersex studies scholars note that these photos have been unethically acquired, shouldn't be used as teaching aids, and in no uncertain terms communicate that intersex traits are disordered and must be fixed. These analyses are apt, and I aim to add to them by asking, why are all the photographs of white people? I posit the photographs constitute an unlikely archive of the racism that's so bound up with interphobia. So when contemporary surgery became common practice in the global north in the 1950s, largely due to Money's theories, the idea that Black people were more likely to be sexually ambiguous was still being circulated, and these issues still persist today. Zine Megubane writes of the rise of intersex medical management in America. Surgery on white patients was, quote, imperative to establish the normality of whiteness. An ambiguously gendered white body needed to be corrected to retain its whiteness, whereas an ambiguously gendered Black body was seen as confirming the essential biological difference between whites and Blacks, end quote. So given that corrective surgery was presumed crucial for white intersex kids, they were the ones in medical theaters apparently available to be photographed. In addition, white people were more likely than people of color, particularly socioeconomically disadvantaged or rural people of color, to give birth in hospitals and regularly engage with the medical institution. People of color invested in culturally traditional home births or had no other option, have different cultural relationships with the sex dyad, or were rightly skeptical of the historically racist medical industry would avoid hospitals. As a result, it stands to reason that some racialized intersex infants were not subjected to the surgical knife. They weren't there to be photographed. So, recounting conversations they had with other intersex people of color, intersex activist Pigeon Pagonis explains, while the medical industry, quote, has no space for you, so Black, Indigenous people of color, on the flip side of that coin, there are also some positives that happen. So say you can't afford to go to a hospital, or going to the hospital just wasn't in your culture, and you had home birth, and you had a doula that's from your community, and this doula, because I've met some people like this doula saw the baby who had intersex genitalia at birth, and the doula was like, their ancestral knowledge was like, it's okay, this baby should be loved and reared and seen as like a blessing instead of rushed off to the hospital. So the photographs are undeniably ethically reprehensible, and I don't think they should be used as teaching tools. Additionally, the photographs of exclusively white intersex people that prospective medical practitioners view reproduce a complex discriminatory story. I'm really intrigued to dive into this line of thinking further as this project progresses. So overall, my preliminary research suggests a lack of intersex competency education will negatively impact the patient-practitioner relationship, clinical assessments and treatment, as well as the intersex child-parent proxy relationship. Rather than reaffirm and reinstitutionalize the male-female sex dyad to the detriment of intersex patients, I think educators and textbook authors must actively oppose the myth of dyadic sex, a myth rooted in racism, queerphobia, and ableism. One pragmatic step to remedy these issues is by actively centralizing intersex people's knowledges in the education process, or more aptly put, the re-education process. So, thank you. I will stop sharing my screen.